A very good evening to everyone. This is the eighth episode of SigTuple webinars. In this episode, we'll be covering anemia, the importance of early screening in women. The session will be taken by Dr. Manjula SJ. Uh, before the session starts, the actual session starts. Let me just fill in the 5-6 minutes on introducing how SigTuple is doing and what are the products of SigTuple, and then Dr. Manjula can take over. And by the time, we'll be giving some more time for other participants also to join, right? So most of you, I think, are aware of SigTuple. So we are a startup based in Bangalore, India. We have been developing microscopy products, automated microscopy products since 2015. We have a product called SigTuple A100. The idea behind that product came from a problem that we are trying to solve, which was when our founders saw in clinical laboratories, they found that all the pathology laboratories are mostly automated except for the microscopy, which remains predominantly manual still, right? The manual microscopic review itself is inefficient because manual review in few cases, few abnormal cases might take up to 20 minutes as well. And it is inconsistent because it is a skill based task. So how it is done depends on or varies with with the level of skill of the pathologist, and it is inaccessible. So we have based on the surveys that we have seen, we have around 100,000 pathologists who have to serve 7 billion people around the world. So fairly, it is inaccessible. But it still continues, the manual microscopy process still continues to be the gold standard for diagnosing several critical disorders. Right. From this problem, what our founders have identified is what they have figured out what our vision and mission should be. Uh, SigTuple then and there decided that we will be automating this error-prone and inefficient manual microscopy process. And we are set to democratize this microscopy process by enabling AI-assisted remote review, which is unhindered by the geographical boundaries. And our current solutions that we are SigTuple has uh, automate 70% of the samples which need microscopy. In future, we plan to automate 100% of the microscopic needs of the lab. The vision, the four vision of our company is to be the global leader in automation of manual processes in clinical laboratories. Right. So from this thought process, we taken up looked at the current laboratories that we have, and we found two opportunities. One opportunity is in hematology laboratory, where we see 4 billion samples per year get tested in hematology analyzer, of which 20% of them get abnormal flags. Right. These flagged samples have a slide has to be prepared from the samples, and this slide has to be reviewed manually by a pathologist qualified enough to observe and diagnose any disorder. Around 96% of these processes are being done manually at this point of time as well, and remaining 4% is being handled by some sort of digital microscopy. This is where the opportunity has been looked at by our founders. And the second opportunity is similar in this similar scenario, urine analysis. So, similarly, how hematology analysis or hematology department works, even in urine, there is a manual microscopic need. To address these two opportunities or to utilize these two opportunities, we came up with a solution called AI 100. It's artificial intelligence 100. It's a one device and multiple tests. The one device can do both, can solve both urine and blood microscopic needs. Right. Shonit is the software that we used for analyzing blood samples or peripheral blood smears. The software we are using for analyzing urine samples for sediment analysis. So they are using this software, the software hardware itself called A100. We are making the manual microscopy needs of blood and urine fairly automated. Right? So this solution is accurate, affordable, and accessible. Accuracy is determined based on all the around 20 plus clinical trials that we have done at major laboratories in India and across the world. And affordability is based on how our competitors are pricing their product, and how we are pricing the product, and our product does not need any OPEX as well. The accessibility, the device has been developed thinking that most of the labs that need this solution or that need the pathologists need might not have a accessibility or physical accessibility or road accessibility and all. For that reason, we have compiled or we have made developed the device with 100% IoT solutions. Like all the device needs is internet. This device will, through internet only, will analyze the samples, and it gets upgraded to the new software that is available automatically. And the reports that are generated by this device can be viewed from anywhere in the world by any pathologist located in anywhere in the world as well. Right? That is a gist of how the our product has been envisioned. And A100 has been compared. We even got this blood solution has even got an FDA clearance as well. And based on our FDA filings and our competitor filings, we are our results are better than their results in accuracy. Right? And with this product, what value we are adding is we can enable telepathy by sort of remote review, higher pathologist efficiency. We can have faster TAT, and we can have standardized quality. Obviously, this is cost effective. Next value addition is this device. Using this device, you can add images to the report that you are generating. For example, if you are when a blood is run in your lab, when you are giving CBC report, you can add images of that particular images of the cells of that particular patient as well on the page or on the report, right? Thereby adding value to that report itself, and giving some evidence or some confidence in that report to the clinician and patient as well. Lastly, we have recently enabled malaria parasite detection as well. This is groundbreaking for us, and this is still under development. But once it is done, it will revolutionize how malaria screening is done in India. So these are few IPs that we have gotten. We have some patents we got. So this is not easy for us, for any company to make. We have done this in record time. Our predecessors, our incumbent competitors took around 20 years, and we took the same thing. We did the same thing or much better job within 7 years. So these are few of our clients, which includes seven of our the top 10 labs and hospital networks in India. And the bottom line, the bottom tier, you mentioned Haribat, THC, Biomed. These are our distributor channels in India and across the world. That's it for the introduction of SigTuple. I think few more people have joined. Now, let me just hand over this session to Dr. Manjula for the next, the actual key point of this, which is anemia, the importance of early screening in women. Dr. Manjula has done her MD pathology from MS Ramaya Medical College in Bangalore. She's currently working as head of department hematology in and senior consultant pathologist for Apollo Hospitals, Bannerghatta Road in Bangalore. She has also worked as a lab head for more than 7 years in Fortis Hospital labs in Bangalore. Her areas of interest include hemato-oncology, bone marrow aspirations, in biopsies, flow cytometry, lab management, and quality assurance of laboratories. Uh, uh, it's a thank you, Dr. Manjula, for accepting our invitation and giving this session. Please take over, ma'am. I'll stop my session.
Thank you, Daka, for the kind introduction. At the outset, I would also like to thank Dr. Reenu for giving me this opportunity. And good evening, everyone. Uh, Thank you all for joining this session on a Saturday evening. Uh, Now, I would proceed with the presentation. Daka, I would like to share the screen.
Please, ma'am.
Can you see my screen?
Yes, ma'am.
Okay, fine. So, good evening, everyone. Today, I will be talking on anemia, which is a simple, very common, and basic topic, but it is a significant public health issue in developing country like India, particularly affecting vulnerable populations such as women and children. The overall prevalence of anemia in India is estimated to be around 50 to 60%, and approximately affects 50% of women in reproductive age, and much even at a higher prevalence in pregnant women, which is over 60%. The risk factors are the menstrual blood loss, that is heavy menstrual bleeding, menorrhagia, which causes significant iron loss. The second is dietary deficiencies. The nutritional deficiency is very common in India. Deficiency or low intake of iron-rich food, folate, and vitamin B12. The third risk factor is pregnancy itself, because in pregnancy there is increased nutritional demands, and chronic health conditions like kidney disease, autoimmune disease, and gastrointestinal disease. So, what is anemia? Anemia is characterized by decrease in red blood cell mass or hemoglobin, leading to reduced oxygen delivery to tissues. So this can be relative or absolute. We call it relative when there is no actual reduction in the total red cell mass, but the anemia is due to increased plasma volume, as in pregnancy or hyperproteinemia, or after aggressive fluid therapy. So we call it absolute anemia when there is an actual reduction in the total RBC mass. So, what are the symptoms and signs? The anemia affects the whole body, and the most common symptom is fatigue, paleness, headache, headache, and in severe cases, uh, uh, the patient may have shortness of breath, dizziness or lightheadedness, rapid heartbeat, cold hands and feet, brittle nails, and craving for non-food items. So, early screening for anemia in women is very crucial. As I already told, the prevalence of anemia is very high in women during menstruation, pregnancy, and postpartum periods. And everyone knows that woman is known for multitasking and has various responsibilities at home, with children, and at job. So, anemia leads to fatigue, weakness, and decreased productivity, affecting daily life and overall well being. So it becomes very crucial for early screening for anemia in women. And in pregnancy, anemia can increase the risk of preterm delivery, low birth weight, and cause developmental issues for the baby. So it is very crucial in pregnancy to detect and evaluate the cause for anemia, so that there is early or timely intervention, and also to screen the underlying conditions, such as chronic diseases like kidney disease, autoimmune disorders, thyroid disorders, and serious blood disorders. So early diagnosis, early screening, and early diagnosis helps in preventing long-term complications and improve the quality of life. It also supports overall health and wellness. So, early screening, early diagnosis helps in guiding the treatment. Identifying the type and cause of anemia early allows for targeted treatment through dietary changes, supplements, or medical interventions. So, what are the most common types of anemia in women? As you all know, uh, uh, nutritional deficiencies is the most common cause for anemia in India. That is iron deficiency anemia, vitamin B12, and folate deficiency. Then the third one is anemia due to chronic disorders like chronic infection, inflammatory diseases, autoimmune diseases, and malignancies. So, with this background, I would proceed with the proceed talking from a pathologist perspective, understanding the our underlying causes, implications, and management strategies for addressing the issue effectively. So, I would be now talking as a pathologist. So, we grade anemia into mild, moderate, and severe degree. Up to 10 gram per deciliter, we call it mild. 10 to 7 grams, we call it moderate. And when it is less than 7 gram per deciliter, we label it as severe anemia. Broadly, anemia is classified based on etiology and based on morphology. Based on etiology, we have anemia due to blood loss, decreased production of RBCs, increased destruction of RBCs. And based on morphology, we classify it into microcytic, normocytic, and macrocytic. So, what all test we order for diagnosis of anemia? The basic test is complete blood count, followed by peripheral smear and reticulocyte count. Complete blood count gives us the hemoglobin value, RBC mass, to classify it as mild, moderate, or severe. And then, if there is anemia, then we look at RBC indices and then we proceed with peripheral blood smear and reticulocyte count. So, based on the findings in peripheral smear and reticulocyte count, we suggest further tests like urine analysis, RFT, LFT, thyroid profile, iron panel, vitamin B12 folate assay, HB electrophoresis, ESR, haptoglobulin, etc. Bone, and finally, the bone marrow study. So, for classification of anemia, by CBC, we know the hemoglobin and RBC mass, and then we have red cell indices, which gives us, which indicates the size of RBC, chromasia of the RBCs. And this is the calculations for MCV, MCH, MCHC. So because the CBC gives us or the values of MCV, MCH, MCHC, I would not stress upon these formulas. The red cell indices are mean corpuscular volume, which normal is 83 to 101 femtoliter. MCH and MCHC gives the indicates the chromasia of RBCs. And RDW, normal value is 11.5 to 14, which gives us the variation in the size of RBCs. So, this is how a normal peripheral smear looks. And when we talk about RBC, we talk about the size of the RBC, shape of the RBC, chromasia of the RBC, and chromasia of the RBC. So, how do we assess the size of the RBC on a peripheral smear? We compare it with the nucleus of a small lymphocyte. When the size of the RBC is equal to the size of the nucleus of a small lymphocyte, we call it normocytic. Less when it is less, it we call it microcytic, and it is when it is more than the size, then we call it macrocytic. And then we talk about chromasia. Chromasia is the color of the RBC. So when the central area of pallor is equal to one third of the size of the RBC, we call it normochromic. And when it is more than one third, we call it hypochromic. And when it is less than one third, we call it hyperchromic. So this is about the uh, size and color of RBC. So whenever there is a variation in the size of RBCs, we call it anisocytosis. This is a picture to show microcytic hypochromic cells compared to the uh, small lymphocyte nucleus. And this is a picture to show the macrocytes This is a macroovelocyte. These are macrocytes, teardrop cells. So, after the size of RBC and color of the RBC, we look at the shape of the RBCs. Normal shape of the RBC, as you all know, it is biconcave disc shape. When there is um, variation in the shape, we call it poikilocytosis, and these are the various poikilocytes which can be seen on the peripheral smear. When the shape of the RBC is like of a pencil shaped, elongated, we call it elliptocyte. When it is round with loss of central pallor, we call it spherocyte. When the central pale area is like a slit, then we call it stomatocyte. When the RBCs are broken, we call it schistocytes. If it is teardrop shaped, it is teardrop cell, sickle shaped cells. Then this is a Burr cell or echinocyte where the RBC surface shows spikes at regular intervals. Acanthocyte when there are spikes on the surface at irregular intervals and irregular size. Then we have target cells which have central area of chromasia surrounded by pale area and a peripheral rim of chromasia. So these are some of the most common poikilocytes we can see on a peripheral smear in different conditions. So target cells most commonly seen in thalassemia, post-splenectomy and liver disease. And this is a bite cell. It looks as if the RBC is bitten in one corner. So commonly seen in G6PD deficiency and unstable hemoglobin disorders. This is sickle shaped cell or sickle cell seen in sickle cell anemia and trait. A teardrop cell, most commonly seen in myelofibrosis. Acanthocyte, seen in A beta lipoproteinemia, liver disease, and others. Burr cells are usually seen in uremia, and this is a hemoglobin crystal. Very rarely we see in hemoglobin C disease and SC disease. So this is Role formation. This is not a poikilocytes, but RBCs are piled one above the other in a stalk, seen whenever there is a increased ESR, commonly seen in chronic liver disease, multiple myeloma, malignant lymphoma, and chronic inflammatory disorder. This is also not a poikilocyte, but to show the agglutination of RBC seen in autoimmune hemolytic anemias. So the RBCs are clumped together. So this is about the variation in shape on the poikilocytosis. The last one, when what we look in RBC is the red cell inclusion. So normal RBC is anucleated. If we find a nucleus within the RBC, it is a nucleated RBC. Nucleated RBCs are immature RBCs which are found in the bone marrow in various stages of erythropoiesis. But in certain condition, it can be seen on peripheral smear. This is a Hubble Jolly body. These are nuclear remnants seen in after splenectomy or asplenia cases. In basophilic stippling, you see small cores or fine blue granules throughout the RBCs, and it is seen in case of dyserythropoiesis. This is a Pappenheimer body um, where this fine blue dots is confined to one area, and these are malarial parasites or parasitic inclusion. This is ring forms of malaria. So this nucleated RBCs we see regularly, and we evaluate for nucleated RBCs. And of course, malaria parasite also is one of the most commonly asked test for on peripheral smear. But the significance of Haematology bodies, basophilic stippling and Pappenheimer bodies depends on the staining of the smear. How good we make the staining, so we can appreciate if the staining is really good. So these are some of the peripheral smear picture to show anisopoikilocytosis, where there is variation in the size and shape of the RBC. This is to show teardrop cells. These are target cells, and this is basophilic stippling. Here we can see sickle cells, schistocytes, target cells, and these are spherocytes or microspherocytes, schistocytes, and these are bite cells, and these are polychromatophilic cells. So I would explain as and when we discuss some case studies. So for diagnosing and evaluating anemia, the classification is very important. As I broadly mentioned, the various classifications of anemia. And with this background, that is based on the size of the RBC, we classify it into microcytic hypochromic when it is less than 80 femtoliter, normocytic normochromic when it is 80 to MCV is between 80 to 100, macrocytic when MCV is more than 100. Again, we confirm it on the peripheral smear examination with that of the comparing the size of the RBC with that of the nucleus of the small lymphocyte. So these are the causes for microcytic hypochromic anemia: disorders of iron metabolism, globin chain synthesis, sideroblastic anemia, lead intoxication. Under normocytic normochromic anemia, we have anemia associated with appropriately increased erythrocyte production seen in post-hemorrhagic or hemolytic anemia, decreased erythropoietic secretion, most common is renal anemia, endocrine deficiency, anemia with impaired marrow response as in red cell aplasia, acquired red cell aplasia, bone marrow infiltration. Macrocytic anemia, we further classify it into megaloblastic anemia and non-megaloblastic anemia. Under megaloblastic anemia, we have most common cause vitamin B12 deficiency, folic acid, and combined. When the macrocytic anemia is not due to any of these deficiencies, we call it non-megaloblastic anemia. Megaloblastic anemia means when we see megaloblast in the bone marrow. So the causes for non-megaloblastic macrocytic anemia is hemolytic anemia, post-hemorrhagic anemia, alcoholism, liver disease, and the list goes on. So after complete blood count, peripheral smear examination, the next important thing which we see on peripheral smear or the next test is reticulocyte count. So what is a reticulocyte? And nucleated RBCs. Nucleated RBCs these are nucleated RBCs, which these are immature RBCs. As you all know that erythropoiesis happens within the bone marrow, and the maturation of RBCs occurs from proerythroblast to early, intermediate, late normoblast, and finally reticulocyte. So when the bone marrow responds to hemolysis or any hemorrhage, the bone marrow becomes hyperactive and produces more and more of, tries to produce more and more of RBCs, and this immature RBCs are pushed to the peripheral smear. So reticulocyte is the last immature RBC, the last stage of erythropoiesis, and this is an immature RBCs. When the reticulocyte enters the peripheral blood, it circulates for about a day, and before it finally matures into mature RBC. So, how do we identify a reticulocyte count, reticulocyte on a peripheral smear? See, these appear as polychromatophilic cells, and the size is a little bigger than that of the mature RBCs. Polychromatophil means like there is two colors, like multiple color. It has a blue tint with the pink color. So these are polychromatophils. But how do we confirm the reticulocytes? So we confirm reticulocytes and we give reticulocyte count on um, new methylene blue stain or supravital stain. So on this is a new methylene blue stain or reticulocyte stain where we see the reticulocytes. Reticulocytes appear as fine dark blue dots or in or threads within the RBCs. So these are the reticulocytes. So how do we give the reticulocyte percentage? So we count the number of retic in n number of fields into 100 divided by total RBCs in n number of fields. So the normal percentage being zero point 0.5 to 2.5%. We normally give reticulocyte percentage only. Some of the automated analyzer also gives reticulocyte count, but the gold standard is the new methylene blue staining. And this is the formula to calculate absolute reticulocyte count if at all required. And there is something called corrected reticulocyte count. I don't know how many actually follow this, but the corrected reticulocyte count is required to give actual reticulocyte count, and the correction is made for based on the patient's hematocrit. Whenever the hematocrit of the patient is low, then the normal reticulocyte count is it's false. Um, there is a false increase in the reticulocyte count. So the corrected reticulocyte count is given by the formula percentage retic into patient's hematocrit divided by normal hematocrit. So, for example, if retic count is 10%, patient's hematocrit is 29, and we take control as 45. So, by calculation, we get it as 7.73%. So, the corrected to give corrected reticulocyte count becomes important because this reticulocyte gives indicates the what is happening in the bone marrow. It indicates the bone marrow condition. So this is, though it appears simple, it is an important test. So to classify anemias based on the reticulocyte count, we give reticulocyte production index. So that is calculated by retic percentage into hematocrit by 45 divided by maturation factor. So what is this maturation factor? It approximately indicates how long it takes a reticulocyte to transform into RBCs once released in the peripheral blood at a particular degree of anemia. That is based on the hematocrit. So, as I told you, reticulocyte usually takes 1 day to convert into mature RBC. So, if hematocrit is more than 40%, the maturation factor we take is 1, 30 to 39.9, 1.5, 20 to 29.9, 2, and less than 20%, 2.5. So, this is the maturation factors for the hematocrit value. So, why is this important? As I told you, it indicates the response of bone marrow. Bone marrow is a very invasive procedure, and reticulocyte production index indicates what is happening in the bone marrow. So, when reticulocyte index is less than 2, it is indicates of hyperproliferative marrow. So the conditions for hyperproliferative marrow, retic index less than 2 is anemia of chronic inflammation, nutritional deficiencies, that is iron deficiency, B12 and folate, hormonal deficiencies, hypothyroidism, chronic kidney disease, bone marrow failure like aplastic anemia, marrow infiltration, and suppression. So, when the index is more than 3 or more than 2, we classify it as hyperproliferative bone marrow. So, seen in acute blood loss due to trauma, GI bleed, uh, any other bleed in any other part of the body, or hemolytic disorders or hemolysis, like under which we have autoimmune, microangiopathic, intrinsic RBC factor, infections, and hypersplenism. Excuse me. So that was about the anemia for based on classification of anemia based on reticulocyte production index. We spoke about morphological classification, and now the last is etiological classification of anemia. And so anemia etiological classification is again broadly divided into anemia due to impaired red cell production, anemia due to excessive red cell destruction or hemolytic anemias, and anemia due to excess blood loss. So under anemia due to impaired red cell production, we have anemia due to nutritional deficiency, anemia due to chronic disease, sideroblastic anemia. It's as the name suggests, etiological classification based on what is the etiology of anemia. So here is the list. So I would not uh, read out each and everything. So then we proceed with case scenarios. So that was about the extensive classification of anemia based on morphology, reticulocyte index, and etiological classification. So now we proceed with the case scenarios. So, first case is a 30-year-old female with symptoms of fatigue, pallor, shortness of breath with exertion, with history of heavy menstrual period for last 6 months, and the blood investigation showed low hemoglobin, low MCV, low MCH, low ferritin, and high TIBC, and peripheral blood showed microcytic hypochromic blood cells. So I have made it simple case scenarios, and then so this is very obvious that uh, because of low hemoglobin, low iron, and increased AIBC and microcytic hypochromic cells. So this is a case of microcytic hypochromic anemia due to iron deficiency. So I actually have taken simple cases so that I can discuss on approach to diagnosis of anemias. So, in this case, so anemia, whenever there is a low hemoglobin or low RBC count, then we look for RBC indices and evaluate MCV. So, based on MCV, in this case, the MCV was low, and MCV, MCH, and MCHC all were low. So, how do we further proceed when the MCV is low or microcytic hypochromic anemia? So first, the most common cause for microcytic hypochromic anemia is iron deficiency. So the next investigation we should be doing is iron studies. So in the iron studies, if we find low ferritin, low iron, and high TABC, we classify it as iron deficiency anemia. When the iron is low, but TIBC is normal or low, and ferritin is high or normal, we classify it as anemia of chronic disease due to infection, inflammation, or malignancy. And iron is normal to high, any TIBC, and normal to high ferritin, then we look for other cells on the peripheral smear. If the peripheral smear shows teardrop cells, target cells, and there is history of splenomegaly and there is a positive family history, we go ahead with hemoglobin electrophoresis to diagnose hemolytic anemias like genetic hemolytic anemias like alpha beta thalassemia, sickle cell anemia, etc. So, if the iron overload is present, then there are sideroblasts on bone marrow. We classify it as sideroblastic anemia. So, there is a picture of microcytic hypochromic anemia, first we do iron studies and then we proceed with other investigations. Uh, the second case is that of a 65-year-old female with fatigue, mild weakness, and decreased appetite. And CBC showed normal MCV and low hemoglobin. So, peripheral smear showed normocytic normochromic red cells. So, we classify this as normocytic normochromic anemia. So, what next when there is a normocytic normochromic anemia? So, how do we approach when there is a normocytic normochromic anemia? So, when there is a normocytic normochromic anemia, we check whether there is increased red cell production or we check reticulocyte count. So, if reticulocyte count is increased, then we suspect hemolysis and look for hemolysis. If there is no evidence of hemolysis, it may be due to recent bleed. Or if there is evidence of hemolysis, then you investigate for hemolytic anemias. If reticulocyte count is normal or decreased, then uh, look for evidence of any renal failure. If at all it is there, then classify it as anemia of renal failure. If there is endocrine failure, anemia of endocrine disorders, and if there is chronic inflammation, then it is due to anemia of chronic disease. If not, then consider a primary marrow problem. Do a bone marrow aspiration biopsy to rule out MDS, multiple myeloma, or infiltrative disorder. Uh, the next case is a 60-year-old female with fatigue, pallor, and tingling in hands and feet, vegetarian diet for last 5 years, recent weight loss, and lab findings: CBC low hemoglobin, high MCV, and low reticulocyte count, and serum B12 is low. And on peripheral blood, we have macrocytic RBCs, hypersegmented neutrophils, some teardrop cells, macroovulocytes. So this is a macrocytic anemia due to vitamin B12 deficiency. So how do we approach or how do we further evaluate if the MCV is decreased or MCV is increased or if it is macrocytic anemia? So the most common causes vitamin B12 deficiency. You look for serum vitamin B12 and folate. If B12 is low, it is B12 deficiency. If folate is low, it is folate deficiency, or combined B12 and folate deficiency can also occur. So if B12 and folate is normal, then you look for other causes of increased MCV. That is, the next comes, you check whether there is increased reticulocyte count, or that also reticulocytes are bigger in size, so MCV may be high. So uh, check if it is due to increased reticulocyte, or look for any liver disease, hypothyroidism, any drug history. So if none of these are present and B12 and folate is also normal, then look for the dysplastic features or other cytopenias, whether WBC count is low or heme platelet count is low. Then if there is pancytopenia, then you do a bone marrow for myelodysplastic syndrome or any other bone marrow abnormality. So, case 4 is a 40-year-old female with fatigue, jaundice, dark urine, and abdominal pain. And there is a recent history of infection and taking penicillin. So, lab findings showed low hemoglobin, normal MCV, and increased reticulocyte count. Peripheral smear shows this agglutination, and this may be a nucleated RBC or so, not very clear, but agglutination is very clear. So this is normocytic normochromic anemia with agglutination, that is uh, suggestive of hemolytic anemia. So how do we proceed when there is a hemolytic anemia picture? So whenever it is suggestive of hemolytic anemia, we have to investigate for other findings like reticulocyte to see whether it is increased, unconjugated bilirubin, LFT, and LDH. So LDH, bilirubin, and reticulocytes are increased in hemolytic anemia, both intravascular and extravascular. So because there is, we have to differentiate intravascular, whether it is intravascular hemolysis and extravascular hemolysis. We have to do further investigations. On peripheral smear, if it is intravascular hemolysis, we see schistocytes, and if it is extravascular, we see spherocytes. Haptoglobulin is decreased, urine hemosiderin is positive, urine hemoglobin is positive, and carboxyhemoglobin is positive in intravascular, whereas all these are negative or mild decrease of haptoglobulin can be seen in extravascular hemolysis. So, what are the different causes of hemolytic anemias and how do we go about diagnosing a hemolytic anemia? So, you have established it as hemolytic anemia based on the initial hemolytic workup like uh, uh, LFT, reticulocyte count, urine analysis, and LDH. Then you see on peripheral blood smear, if you see schistocytes, then you check for history of trauma. If there is history of trauma, then you consider march hemoglobinuria or mechanical valves or recent bypass. If there is no trauma, history of trauma, then you ask for any history of rash or infection or travel. If there is history of infection, then you ask for history of rickettsia or HIV or malaria. Then there is, if there is no infection or travel, then you can classify it as microangiopathic hemolytic anemia or thrombotic macroangiopathy, and these are the further classification of this. And in pregnancy, if at all there is, if it is a case of pregnancy, then you look for liver function test, urine analysis, maybe due to HELP syndrome. And these are the other causes. On peripheral smear, if you are seeing sickle cell, then sickle cell disease, you do a sickling test and HB electrophoresis. If you see bite cell on peripheral smear, then it is due to G6PD deficiency. You confirm it by G6PD activity tests. Then, if it is non-specific, then you think of history, take drug history. If you see elliptocytes, consider hereditary elliptocytosis. And if there are spherocytes, then you do a direct Coombs test. If direct Coombs test is positive, look for drug exposure. If there is drug exposure, then you call it drug induced immune hemolytic anemia. If there is no drug history, then you have to consider autoimmune hemolytic anemia and you have to distinguish warm versus cold antibody or secondary antibodies. If direct antiglobulin test is negative, then you consider hereditary spherocytosis and you suggest for osmotic facility test or using as maleimide testing. So in our case, so there it was a case of autoimmune hemolytic anemia. So there was a drug history as well due to infection. So last two cases. So case 5 is a 28-year-old female with symptoms of fatigue, recurrent infections and easy bruising, recently treated for viral hepatitis. A lab finding CBC showed low hemoglobin, low platelet count, low white cell count and normal MCV. So there is pancytopenia and normal MC. So till now, till case 4, I talked only about peripheral smear. This is just for the completion sake. I have included two cases where we diagnose on bone marrow aspiration and biopsy. So bone marrow aspiration showed hypocellular marrow. These are fat spaces, and there is relative increase in lymphocytes. And this on biopsy, the cellularity is extensively reduced for a 28-year-old female, and there was mild lymphocytosis. This was a case of aplastic anemia. Last case is is of a 72-year-old female with symptoms of fatigue, recurrent infection, and easy bruising, and there is history of long-term exposure to chemotherapy for breast cancer. Lab findings CPC showed low hemoglobin, high MCV, abnormal cell morphology, and biopsy showed dysplastic changes in the hematopoietic cells. So these are erythroid dysbiosis where there is lobulation and multinucleation and vacuoles in the cytoplasm. And on pearl stain, there are sideroblasts. And these are myeloid dysplastic features. There is hypogranularity and there is variation in the size of the neutrophils and irregular or abnormal bridging. And here it shows hypolobated neutrophil, Pelger-Hewitt anomaly, all that. So this is to show megakaryocytic dysplastic features, hypolobation, then nucleocytoplasmic synchrony, hyperlobation, and micromegakaryocytes are the dysplastic features in megakaryocyte. So this was a case of myelodysplastic syndrome, which we have to confirm on cytogenetic studies. So that was about some case scenarios. So coming to the end of this talk, so basically we started with a screening of anemia in women. Then I spoke about pathological aspects of classifying and approach to diagnosis of anemia. So, empowering women with knowledge about their health, symptoms of anemia, and importance of regular checkups can facilitate early detection and management. So, there are many government initiatives as well, such as National Anemia Control Program, which aim to address anemia through supplementation, dietary education, and public awareness campaigns. So the management strategies are by dietary modifications, encouraging iron-rich food, supplementation by giving iron supplements for diagnostic deficiencies, and vitamin C to enhance absorption, and addressing the underlying condition. So the burden of anemia in India is a pressing public health concern necessitating continued efforts in prevention, diagnosis, and management, particularly among high risk groups. So it's a complex issue. Anemia is a complex issue in women's health and it requires a multidisciplinary approach. So we pathologists play a crucial role in diagnosing and guiding management, ultimately improving the quality of life for affected individuals. So collaboration with other healthcare professionals like dietitians, gynecologists, and primary care providers ensures comprehensive care for women dealing with anemia. So these are the references. Thank you for patient hearing. Any questions? Hello, Daka, can you hear me?
Yes, ma'am, we can. First of all, from SigTuple, thank you, ma'am. Thank you for taking this session. It was really informative, detailed, and comprehensive. To the team who have joined, please do let us know if you have any questions on the session or anything else as well. I think we have one question from the message board from Dr. Vidya. The question is, how do we give cystocyte count? How many cystocytes are important?
Okay. Schistocyte count is significant. Like some schistocytes can be seen in iron deficiency anemia or severe hemolytic anemia, some iron deficiency anemia as well. But the schistocytes are important when we give when there is renal condition or hemolytic anemia of significant importance is if we see normocytic cells and there are schistocytes, then it becomes significant for, especially for a nephrologist. So we give a percentage of schistocytes on smear on high power. So more than 1%. That is, we give it in percentage when we get request. Specifically for schistocytes, we get request peripheral smear for schistocytes. So more than 1% in the presence of normocytic normochromic RBCs becomes significant. We call it significant when it is more than 1% and the RBCs are normocytic normochromic.
Yeah,
Or if
ma'am.
it
Dr. Vidya had just added to her question. She said in case of microangiopathy and DLC.
Yeah, that's what. In such cases, so we call it significant and we give it in percentage. For 100 RBCs, how many schistocytes are there? So if it is more than 1%, it is significant in such cases. So otherwise, in other hemolytic anemias, it can be seen, schistocytes are can be seen, but it is not diagnostic. We have other investigations to do. But for such cases, then more than 1% in presence of normocytic normochromic RBCs is significant. Any more questions?
Sorry, ma'am, I was on mute. Dr. Vidya had acknowledged that she
Hmm.
understood the solution. Now,
Okay.
there is one more question from Dr. Prasanna Krishnan Subhadra. The question goes, how to differentiate acanthocytes from procedural and artifacts?
Procedural artifacts, yeah, it is very difficult. So uh, the thing is, then you have to, like, if you see more of acanthocytes, you have to, and if you suspect the staining quality, again you have to repeat the stain with proper protocols and procedures, clean the slide properly, do the smear properly, and it should not be old. Old sample more than 1 day can give artifactual, acanthocytes, and also cleaning of slides is very, very important. So if you follow the protocols properly, then there is less chance of artifactual acanthocytes. And also old sample, there is more of acanthocytes. That again it becomes a false positive. So when you have to report acanthocytes, then you have to be a little careful. You are sure that there are no artifactual acanthocytes.
Yeah, Dr. Prasanna had acknowledged the response, ma'am.
Thank
Any
you.
other questions for him? Yeah, we already crossed 3 minutes. We already crossed 7 p.m. Deadline. We'll close the session for now. Thank you everyone for joining, and most of all, thank you very much for Dr. Manjula for taking up your time and
Thank
giving
you
us
all.
this informative and insightful presentation. Um, everyone, you can we will be sending a link with the recording of this session to everyone who has joined, and you will also get the links, YouTube links of all the sessions that has happened so far under the SigTuple webinars banner. And thank you all. Thank you very much. Thank you, Dr. Manjula, again. And I'll be closing this session now. Have a great weekend and have a great March. Thank you all.
Thank you, Dr. Thank you, everyone.